Hello and welcome to Beckman Coulter's sponsored webinar, Going Beyond Cell Counting and Solving Common Problems Faced by Laboratories. I'm Kalia Stallings from Beckman Coulter's Global Public Relations and Media team, and it is my honor to introduce to you Dr. Fernando Chaves, our Scientific Affairs Director. Dr. Chaves received his MD from the Federal University of Sao Paulo, Brazil. He is board certified in anatomical and clinical pathology after his residency at Boston University. He is also board certified in hematopathology after his fellowship training at UCLA. He has published numerous scientific articles describing novel utilizations of data that are readily available from hematology analyzers. He has been working as a Global Scientific Affairs Director at Beckman Coulter since 2010. Today, Dr. Chaves will discuss on how technological advances with Beckman Coulter's DXH800 and DXH600 analyzers are bringing practical solutions to address problems faced by labs and the clinicians in helping their patients. After today's webinar, you'll understand how this technology can help labs achieve optimal patient care with accurate counting, automated detection of important morphologic changes, while minimizing workload impact due to decreased false positive flagging rates. At this time, I will turn it over to Dr. Chaves. Please feel free to submit your questions during the presentation, and Dr. Chaves will answer as many questions as time permits during the Q&A session. Dr. Chaves?
Thank you very much, Kalia. It's a big pleasure to be with you today. Good morning or good afternoon in which part of the country you are. So today we'll be talking about the technology that we have in place in the DXH800 analyzer. And I think more importantly, just talking about the technology, we will show to you how this technology is used to be solving common problems in the laboratory so that we can actually achieve a better patient care and at the same time minimize workload. So we're going to start this presentation, and first I'd like to set the stage to what is the clinical need that we are addressing with our technology. So what is hematology really made of? And we will understand why there is a lot more that we should be doing in the lab instead of just counting cells, which is what we've been doing for the past 50 years or so. And increasingly, as the laboratory hematology has moved away from the microscope, we also are forgetting the importance of morphology, of the size and shapes of the cells. And that is critical because all this morphological information can really give us a lot of important diagnostic information, and we are missing it behind. We are almost becoming sellers of numbers to clinicians, when in reality the job of the laboratory is to be a consultant, to be a partner in patient care. So now we have technology that allows us to be analyzing the morphology of the blood at the same time when we are counting cells. And that is really important because we can detect these morphologic abnormalities, and therefore we can prevent a patient who has changes in cells that can carry important meanings to the clinicians. We can prevent this sample from just being reported out with normal counts and nobody realizing that this patient was not really just another healthy individual doing a CBC count. So we're going to discuss how the technology works. And we're going to divide this discussion in two aspects. One is the side of the technology, how customers can use it, and they can actually take control of their analyzer and use it to flag for abnormalities that are important for them. But at the same time, we will also talk about how the technology is deployed also for the counting of cells. Because you cannot forget, this instrument is also supposed to count cells. It's not before anything that it's role. And in terms of counting cells, the major problems that we have is not really the counts. All instruments, all technologies do a pretty decent job in counting cells. The problem is, when do I have interferences? So way too many times the instruments have to stop, they have to flag a sample, and a human being has to go and see what went wrong. And that caused a lot of increased costs and labor demands on laboratories, and this is really a time when this is a problematic issue for them. So with our technology, we are really For a number of situations where we have interferences, we actually have empowered the instrument to solve a lot of problems for the lab without they even knowing that it's happening. And we're going to see more in this presentation. Now again, why is morphology so important? Basically, when we look at blood under the microscope, imagine that we were back in 1940 or 1945 when there were no instruments yet, and you had a human being reviewing the blood under the microscope. He would be counting cells. That is the main purpose of that activity. It would be to be looking at the cells of the microscope and recognizing, okay, this is a lymphocyte, it's a monocyte, there's a lymphocyte, there's a lymphocyte, there's a neutrophil, and I'm counting them, right? Either technologists or pathologists. But at the same time, when I am counting the cells, I am also evaluating their morphology. So if I see a neutrophil that has very heavily granulated cytoplasm, this can carry a clinical significance. Or if I see a monocyte that is large and activated with histiocytic features, or if I see a lymphocyte that is also very large with low nuclear to cytoplasmic ratio, all these morphologic changes they don't necessarily make a diagnosis, but they can have an important significance. And just as some examples here, the images that we are seeing here, those are traditional morphologic changes in neutrophils that have been well described in the literature for over centuries, over a century at least. These are changes that have been associated with bacterial infection and sepsis. So here you have a dolly body in the cytoplasm of this neutrophil. Here you have toxic granulation, where this neutrophil, instead of having just a few pink and purple granules, they have very heavy granulation. Vacuoles in the cytoplasm in the lower left, and you have band forms. So all these changes are critical because we know today that the sensitivity of the cellular counts for sepsis and bacterial infection is less than 50%, maybe less than 60% for sure. So that means that a patient may have overwhelming bacterial infection, even sepsis, and they may have a completely normal white blood cell count and neutrophil count as well. And today, these results being reported out to a clinician, the clinician is going to not suspect sepsis, and they may even discharge the patient, and the clinical consequences can be terrible. Now, what is really, really sad is that the morphologic information that could have allowed us to reach a diagnosis was sitting in the blood, but we never looked at it. Why? Because we don't go to the microscope anymore for every sample. So what we need now is technology that is, besides counting cells, it is also evaluating the morphology, so that when I have a sample with these changes, even if the count is normal, the instrument is telling me that the morphology is not normal, and I should be reviewing the sample at the microscope. Another example here, I have examples, for example, atypical lymphocytes. These are cells with larger lymphocytes than normal, much more abundant cytoplasm, so the nuclear to cytoplasmic ratio, the NC ratio, is lower. And that has been widely described as a change in viral infections. Hypersegmented neutrophils. This is another change that we know is associated with deficiencies of vitamin B12 and folic acid, which is also another important abnormality in the blood. Myelodysplastic syndromes, for example, which is another important change, a disease that most patients who are diagnosed with MDS, they do not have symptoms yet. You don't want to wait until they have symptoms to make a diagnosis. And today, most of these patients that are diagnosed by pure incidental findings, basically. They do a CBC for whatever reason, and the cells counts are very low, and you detect these patients. But in reality, many times, you may have a patient whose counts are not absurdly low. They are still, on the borderline low, so they don't trigger a SMER review. And if you don't trigger a SMER review, you don't go to the microscope, you never suspect that this patient had a myelodysplasia. And you miss an opportunity for a diagnosis. So this is another example of the morphology, the fact that we are not appreciating morphology anymore, and how we are losing an opportunity to provide an optimized patient care to everybody who gets a complete blood count in a laboratory. So now that we understand this limitation, how can we address this with technology? We need instruments that, besides counting cells, that are also checking the morphology for us. And this is what we do in Beckman Coulter Hematology. So here you have our core technology, which is called VCS Technology. So these are three different parameters that we look at in each single cell, and allows us to actually look at the cell with a set of eyes. And it's very unique to Beckman Coulter because we don't actually treat the cells in any way. Other technologies, we have to stain the cell with fluorescent dyes, with chemical dyes, to know if the cell is a lymphocyte or a neutrophil, etc. Therefore, they can count cells, but by using these dyes, they are not really evaluating the morphology. In our technology, we don't treat the cell in any way. We just look at it. We look at them. And we look at them with a set of eyes. And the VCS core technology, these are the eyes of the DX800 instrument. So let's go and see how that works. The volume is basically the Coulter principle. Whoever works in laboratories knows this principle very well. Basically, what the volume is an electric measurement by impedance, where we have a positive electrode in one side and a negative electrode in the other side of the analysis. And what we will see is that when you have the fact that you have a positive and negative electrode, this basically generates an electric current in this area. And every time you get a cell passing through the area of analysis, the cell blocks this electric current. Once this electric current is blocked, you have a voltage differential. So I can basically get a milliliter of blood, run it through an area of analysis, an aperture we call it, and I can measure how many pulses of voltage differential I got. And that's my number of cells per milliliter. Now, the impedance of this pulse is directly proportional to the size of the cell. So by this Coulter measurement alone, I can tell that the size of the cells. Again, size of the cell is one of the features that a doctor is looking at when he is trying, number one, to count the cells, so to classify, is this a neutrophil or a lymphocyte? I have to classify the cells so that I can count them. And we classify them based on, among other features, the cell size. And the same feature is being captured by the instrument. The second parameter we look at is the conductivity. Basically, the conductivity is like a radio. We are throwing waves of sound at the cells, and on the opposite side, we have a sensor that is measuring how much sound arrives there. And we know that cells that are more dense, they have higher conductivity. This is the same as if you go on the ocean or a lake and there is a boat nearby or a jet ski with an engine. We know that when your ears go under the water, that the sound, the noise of that engine becomes louder to you because water is a better transmitter of sound because it's more dense. So this physical principle is the exact principle that is used in our instruments. A cell that is more dense can transmit the sound better, and as a result, we have higher conductivity. Now, how does density translate into morphology? Well, the nucleus is more dense than the cytoplasm. Therefore, if you have a cell who has a higher proportion of nucleus in its overall volume, then you have a high conductivity. So that's a measurement of nuclear to cytoplasmic ratio, or what we call MC ratio. The other parameter that we look at is the laser light scatter. We will hit the cell with a laser, and we have a photosensor in the LH instruments at 45 degrees of angle. And what that will do is it will basically allow us to measure of that laser how much light was scattered when the cell passed in front of this laser. And we know that if a cell has more granules in the cytoplasm, or if the cell has a nucleus that is not nice and round, but is more irregular and divided in multiple lobes, these cells will scatter more light. So as you can see, with the laser light scatter, we are measuring granularity of the cytoplasm and lobularity of the nucleus. With the conductivity, we are measuring the nuclear to cytoplasmic ratio. And with the impedance, we are measuring the cellular volume. All these features, cytoplasmic granularity, lobularity of the nucleus, and MC ratio size, they are the exact same morphologic features that a pathologist or technologist is using to classify a cell and count them. But they are also the exact same morphologic features that we evaluate in the blood when we are hoping to capture if a patient has a change that could have important clinical significance, like a viral infection when you see an atypical lymphocyte, which is larger and has a lower MC ratio, or a suspicion of MDS when you have a hypogranular neutrophil, with fewer granules in the cytoplasm, or suspicion of sepsis and bacterial infection when you have a large activated neutrophil. So the key point is, if we can use these morphologic features to recognize cells with our eyes, and not only recognize and count them, but also suspect, flag for the abnormalities, and if the instruments are looking at exact same features, why can't we use the instrument to also capture and evaluate this information for us? And how do we do that? So we know that we have now VCS, we understood how that works. How do we transform that into information to be used for the instrument? We'll go over that now. Now, what we do have now in a new instrument called the XH800 is that we don't have only one laser light scatter, we have 5 different angles of light scatter. And that is important because now we have 7 different measurements. Instead of having volume, conductivity, and scatter, we have volume, conductivity, lowest angle of light scatter, which is the light scatter at only 1 degree of angle, and we call that actual light loss, or ALL. Then we have lower angle light scatter, which is a light scatter at 9 degrees of angle. Then we have lower medium angle light scatter, which is the light scatter at 9 to 19 degrees of angle. And then I have upper medium angle light scatter. Now, this is important because when we go to the next slide, we will see that these parameters are used to plot cells in a histogram. And the way that we classify cells and we discriminate cell A from cell B is based on the position of the cell in the histogram. Now, if I have 7 angles of light scatter, 7 parameters with 5 angles of light scatter, I don't have only one histogram that I can create. I can create multiple histograms by combining any 2 of the 7 parameters. So I can combine volume with the conductivity, that's one histogram. Then I can combine volume with actual light loss, that's another one. And with the other 4 angles of light scatter. So I now can have 6 histograms created by combining volume with the other 6. Then I can get conductivity and combine with the 5 angles of light scatter. That's 5 more histograms and 4 more histograms, etc. So I have abundant new data, abundant new histograms that can be used to isolate and classify particles. And this is why we can avoid interferences. This is the use of morphology to avoid interferences. So let's see how these histograms are generated and how we are using this information to both allow for a better counting without interferences thanks to the multiple angles of light scatter, and at the same time allowing for an automated detection of morphologic changes in the cell. So basically, once the volume, the conductivity, and the laser light scatter parameters are measured, the instrument will give points to each one of these parameters. So for the volume, the points can go for all of them. You can grade the cells. You can give the cell a score from 1 up to 256 points, okay? And then, based on this score, the cells are going to be plotted in a histogram. So you have here the volume laser light scatter histogram. So the bottom is 1 point. If you go up, it goes up to 256 points. And on the left is 1 point. And if you go to the right, it goes up to 256 points. And each dot in this histogram is a cell. And the position of this dot, the position of this cell, depends on the score that that cell got for volume and for laser light scatter. So, for example, a cell that is further up in the histogram is a larger cell than a cell that is lower in the histogram. Now, because the position of the cell depends on the morphology, and we know that white cells, leukocytes, that all belong to the same type, they're going to have similar morphology, naturally, they are going to create populations. So I have here a green population, a pink population, and a blue population. And we know that each one of them represents a subtype of white cells. And then all the instrument has to do is count how many dots I have in each one of these populations. And this is my white blood cell count, my differential count. Now, you don't need to know the color by memory to know which population is which cell type. Because, remember, the morphology directly relates to the position of the dot in the histogram. So then we can basically, if I tell you that the blue population is composed of lymphocytes, I don't have to memorize that to know it. Because we know the lymphocytes are the smallest leukocytes in the blood. And therefore, they will be lowest in the histogram. That's because they are smaller. And that's where you have the lowest volume measurements. By comparison, the monocytes are the largest cells in the blood, and therefore they're going to go up in the histogram, and that's why they are the green population. And the neutrophils, they have more granularity in the cytoplasm, and they have a more low beta nucleus than a monocyte and a lymphocyte. And that's why they are to the right in the histogram, and they are the pink population here. Now, how can I use this to detect morphology? Because these measurements, this volume, this light scatter, we actually measure for each population the mean volume, the mean light scatter, the mean conductivity, and we also measure the standard deviation for each one of them. And these numbers, because they are directly related to the morphology, they are basically quantitative measurements of cell size, of cell granularity, and of cell nuclear to cytoplasmic ratio. And we can now use the decision rule ability of the instrument to flag every time a sample comes where your lymphocytes are too large. You can flag those. Or your neutrophils are too large, you can flag those. Or your neutrophils have too little laser light scatter because they're hypergranular, you can flag those as well. And therefore, we can get the instrument to do an automated morphologic check for the laboratory. So basically, you can go back to doing what we should never have stopped doing in the laboratory, meaning that every time we get a blood, we will do a count, all right. But besides that, we will also verify that this blood does not carry any morphologic abnormality that is clinically relevant to the clinician. We can verify that, and if nothing is wrong, the morphology is all within the normal expected range for this instrument, we just report all the results. And you're going to do exactly what you do today. You just get a sample of blood, you put it in the instrument, and you report out a CBC. Everything is fine. But what is critical here is that you looked for morphology changes. And if they were present, you would catch them. And that is a major game changer in the quality of care that we are providing to our patients. So as you see, this is basically with the additional advantages of the DXH800, we have better resolution in the morphology changes, we have better opportunities to be capturing these clinically relevant morphologic abnormalities. Now, why is this important? Let's take a look, let's make a comparison here to looking at a new parameter, okay? So for example, we just described the importance of neutrophil morphologic changes when a patient has sepsis. And that is one opportunity that we have to improve the patient care. Now, we have other approaches, like other companies which are looking at immature granulocyte counting for that. And where is the problem that we see? So for example, look at here at the maturation of neutrophils. They don't go from a blast to a promyelocyte to a myelocyte immediately. This is a continuous maturation. So basically, as you can see here on the lower right, we have an image. I have 3 cells here. I don't think anybody can confidently say that they are either neutrophils or bands. You know, you have arguments that could push either way. You know, you can say that these are bands because they are not perfectly separated into lobes, but at the same time, there is a stricture in the band area, so they basically could also be called neutrophils. It's really a very subjective area. And why is that subjective? Not because you have problems with technology, but because that's how the biology works, right? So basically, you have here a problem. And do you think that instruments or technology can solve that? Not really, because this is not a limitation of the technology. This is a limitation of biology. Instruments can discriminate a lymphocyte from a monocyte because in the human body, you do not have a cell that is intermediate between a lymphocyte and a monocyte. And instruments can discriminate a neutrophil from a lymphocyte because we do not have a cell that is intermediate between them. So when you look at the histogram, you have a valley, you have a perfect separation between each one of them. Now, if you want to discriminate a band from a mature neutrophil, here you have our pink population, which is your myeloid population. In the blood, it should be predominantly neutrophils with maybe a few bands here and there. Now, if I wanted to identify immature granulocytes, those that are more immature than bands, right? I know for a fact that they will go up in the histogram because they are larger by default. But where do I draw the line? There is no valley here that perfectly separates your metas and myelocytes from the bands. So it really becomes very difficult to do that. And what you're seeing is that those who have tried, they end up creating a new parameter. It's very easy to create a gate around a portion of this population, count how many dots fall in there, and say, hey, we have a new parameter, immature granulocytes. You could have done that for monocytes, for any one of them. But the question is, are we achieving a better diagnostic performance than what already exists? And when you look at the literature, you will see that these measurements of subsets of cells that are not perfectly isolated, they will have just an equivalent performance to just counting the cells, which is suboptimal. So here you look at this histogram, and on the first look, it feels like you have two histograms, two raw curves. But if you look very carefully, there are actually three of them. There is a red one, which is the lower performance raw curve, but there is also two other curves, a green and a blue curve here in this image. And the reason they are so difficult to distinguish from one another is because they perfectly overlap each other. And when two raw curves overlap, that basically means that the two tests, the two laboratory tests that they represent, are basically the same performance. And there is no reason why it would change from one to another. And what are those tests? The immature granulocytes and the absolute neutrophil count. So basically, you know, the idea of counting subsets and creating all these new parameters is not really helping clinicians in providing improved patient care, when the real need is actually to go back in there and make sure that we capture these morphologic changes. And that's what we do with the DXH800. We have the technology to evaluate morphology, as you saw, to capture the cell size, the granularity of the cytoplasm, the lobularity of the nucleus, and the NC ratio. And we capture this information, but it also gives you here, flagging rules, the ability to write decision rules so that you flag samples that may have relevant morphologic changes and that you would miss if you do not have this technology. Now, on top of that, what we're also doing is, after we give the instrument the ability to flag samples, it is also important to understand which patient gave us the sample. So, for example, a patient with atypical lymphocytes, and we just described how they look like. They are large, they have a lower NC ratio, and we just described how the instrument is capable of flagging those cases, those changes for you. Now, once you go to the microscope after you see this change, the next question, once you identify this, who is this patient? Who is this patient that is giving me atypical lymphocytes on the microscope? Because it might be a teenager with a fever and enlarged lymph nodes on the neck, and then you say, well, this looks like a viral infection, mononucleosis, which is a completely different significance if I tell you that the same cell is coming from a patient who is a middle-aged man who has been treated for lymphoma. Now your differential diagnosis is completely different, and the relevance for the patient is also different. Therefore, the identification of the morphology is part of the big picture, but also the understanding of which patient is sent in the sample is also part of it. And therefore, we have included, besides in the decision rules, besides the morphologic information, the customer can also incorporate patient information into the decision rule. They can use the age of the patient, the gender, the location of the patient, the nucleocyte, the location of the patient, the ordering physician, the diagnostic code. Any patient information that arrives at the DXH800 instrument can be used to be written in a decision rule, so that, for example, a laboratory can have a large neutrophil flag, which is, as you discussed, can indicate a bacterial infection, but they can choose to use this flag only in neonates when the change is more relevant. This allows the laboratory to have a perfect combination, a perfect balance between the amount of work they're going to put, because when a sample is flagged, you have to make a manual review, and that's a lot of work. A balance between that amount of workload versus the quality of the patient care that the laboratory is offering. So really, it becomes almost like an automated hematological consult for every single patient. And this is one side of how we in Beckman Coulter are using this morphologic feature to improve patient care and address this huge need the laboratories have, which is the need to appreciate morphology at the same time that a cell count is being performed. Now, we have not forgotten that counting cells is also important. And because cells are identified based on the morphology, we can also tap into the morphologic features to have an accurate counting and to minimize the number of situations where we can have an interference. And that is also thanks to the new angles of light scatter. So remember, we just described how in the LH instruments, the pre-DXAG instruments, and actually in all other instruments in the market, they all will recognize certain features of cells. In our case, we recognize morphology. Others will recognize fluorescence or chemical staining, etc. But regardless of what technology was used to recognize certain features of cells, cells must be plotted in a histogram, and it is the position of the cells in the histogram that is going to allow the instrument to know what type of cell you're dealing with. Now, a core limitation of all instruments arise from the fact that they only have one histogram. And if I only have one histogram, I only have one certain amount of space to place particles in there. And if two different cell types end up going to the same position in the histogram, the instrument has no way of knowing that it is either cell A or cell B. And I can have problems. There are two things that can happen here. And the two are very problematic for the laboratory. You can have a situation where the instrument reports a count and doesn't alert you that there was an interference. And then your problem is that you reported wrong results. And the other problem is that maybe the instrument was able to detect that something was off and caught the abnormality, but the problem now is the fact that you're going to have a lot of workload to have to make a microscopic smear, have to go into the instrument data, recognize what is happening, and that is also problematic because laboratories are overstaffed and underpaid and are having a very big challenge in addressing the clinical needs, especially if you have to be going to the microscope and involving manual labor so many times. So how can our new histograms help? Well, they help because if the major limitation is a space problem, I have one histogram and I have way too many particles, way too many different cell types to plot in that histogram. And now I'm telling you that the DX800 has new angles of light scatter. And the new angles of light scatter can be used to create new histograms. So now I have more space, basically, to plot cells. And we are learning now how this space has been tremendously valuable to isolate different cell types and avoid interferences. So let's take a look at some examples here, okay? So this is a very common problem faced by laboratories. The presence of cellular interference in the white blood cell counting. So what we are seeing here on the left is a normal histogram. We are going to use impedance to count white cells, and starting at 35 femtoliters on the left here, this is when we start counting white cells, and your curve should start at the 0 area. Now on the right, where the arrow is, you are seeing that the curve has what we call a high takeoff of the histogram, of the curve. Why is that? Because you have particles that are just about 35 femtoliters, which is where the measurement starts for counting whites, and these particles are messing up your white cell counts. They could be, there's so many particles that can fall in this part of the histogram. You can have nucleated RBCs. You can have giant platelets. You can have platelet clumps. You can have even malarial parasites. They all can go in there. And you know what happens up until the DX800? There's nothing you can do. You can just alert the customer that there's a problem, and they have to do the work of figuring out what happened and cleaning it up. Now, thanks to the DX800 and new histograms, we are being able to isolate these different interfering particles. So here we have giant platelets, and as you can see, they can be as large as a white cell, and that's why they're causing cell interference. Well, in this histogram here, which is a unique DX, it's one of the new histograms. Let's discriminate new histograms from traditional histogram. The traditional one is the one that every instrument had before the DX800. It's typically one for size and one for granularity. So we had on the LH analyzers volume versus laser light scatter. Our competitors might have forward fluorescence versus side fluorescence, right? In this traditional histogram, they may all fall in the same area. But now we have a new histogram here, which is created by low-angle light scatter against actual light loss. And look at the position of the giant platelets in this histogram. And let's look at the position of platelet clumps, which is another abnormality causing exactly this problem, cellular interference. in this new histogram, they are in a completely different area. At the same time, nucleated red blood cells also are in a completely different area, as you can see here. Therefore, we can now count nucleated red blood cells with much better accuracy, and therefore, these cells are not causing interferences anymore in the white cell counting. This means, number one, that the counts being reported by the instrument are more reliable, and the likelihood of reporting out a false leukocytosis because nucleated reds ended up being counted as whites is tremendously decreased because of this optimal detection that we have now, thanks to this new histogram, and that has been reported out in the literature. But at the same time, it also is allowing us to even if you had an instrument that could have detected that there was an interference, now we don't have to work to clean this interference anymore because the instrument is already doing that for you without any additional workload. The same also for parasitized RBCs. Here you have blood cells with malaria parasites infecting them. They also can cause cellular interference, but they also have a completely different position in the histogram, as you can see here. So here we have, on the upper side, we have one patient, and on the bottom, you have a second patient, and on the left, you have this patient's histograms at the time when they were diagnosed with malaria, and then in the center during treatment, and on the right, you have after treatment. And if you look where the arrows are, they are showing a very small green population. So this is the position of malarially infected RBCs in this histogram, which is completely different from the position of nucleated RBCs, which is completely different from the position of giant platelets, and completely different from the position of platelet clumps. So now we can discriminate them all and clean it for you. Another very nice example of this, how this technology is helping patients is on the reticulocyte counting. So let's go back into how this works. So for example, when we are counting retics, we must understand that inside the hematological analyzer, we don't have only one instrument. We actually have many instruments inside the same box. We call these instruments chambers. So you have a white cell chamber counting whites, and you have a red cell chamber counting reds, and you have a retic chamber counting retics. And the treatment of blood in different chambers is different. So for the retic chamber, we have to actually clean the hemoglobin of the cells when we're going to count retics. Why? Because the retics are differentiated from the reds because they have remnants of RNA in the cytoplasm. And we have to stain these remnants of RNA. We use a dye called supravital dye, new methylene blue, and we stain the RNA remnants. And then when we run this blood in the laser light scatter, the remnants of RNA the stained ones cause a high laser light scatter. Now, in order to stain them and be able to discriminate that from other cells, we have to completely clear the hemoglobin from the cell. And we do that by adding a very light acid to the blood. This process of cleaning hemoglobin, we call this dehemoglobinization, or the better yet, we have a term which is ghosting cells, right? We have here on the right, you can see reticulocytes with the little blue dots in them. This is reticulin. This is basically RNA stained with methylene blue. And then you have the pale blue cells, which are ghosted RBCs. Now, of course, when I run this sample on the right in the laser, your reticulocytes that have these little blue dots are going to have a higher laser light scatter. And that's how we measure them. But the problem is, if the ghosting process failed, okay, if the cleaning of hemoglobin did not work well, I'm going to end up with cells that are unghosted. So they are not reticulocytes, but they have remnants of hemoglobin in the cytoplasms. And therefore, they also have a high laser light scatter, and they end up going exactly in the position of the reticulocytes. Also, if you have inclusions on your RBCs, you may have Pappenheimer bodies. You may have Heinz bodies. These are all inclusions that mean that when you run the cells on the laser, they will also have a high laser light scatter. The result is that if you go in the literature and you see, if you type in on PubMed, pseudo-reticulocytosis, you will observe a tremendous number of papers describing many conditions that give you a falsely elevated reticulocyte count as reported by hematological instruments. Why is that? Because the instruments are basically counting cells with high laser light scatter. And until the DXH800, they had no way of telling that these cells are not reticulocytes, that they are an unghosted RBC. Now we have the DXH800 with multiple angles of light scatter. So let's look at these 4 images here. And don't look at the visuals, okay? Here we have both density plots and surface plots. That doesn't matter. You can transform the density plot here in a surface plot. That's not the question. The question is the parameter that is being used. And for these 4 images, the one on the right, the one that is a density plot, you see that the parameter is volume versus light scatter. This is the traditional histogram. And you can see in purple the position where the reticulocytes go, okay? Now on the left, in the surface plots, the parameters being used to create this histogram, they are not volume and laser light scatter. They are actual light loss, which is one angle of light scatter, against upper median angle light scatter, which is another angle of light scatter. So this is basically one of the new histograms that are unique to the DXH800 technology. So note that you are seeing a population of yellow cells, yellow dots, that you can see in a clearly different position from the purple dots. They are different in the new histogram. But when you go to the traditional histogram, the volume laser light scatter, you can see that they are exactly in the area where you expect reticulocytes to be. Now, thanks to this having this new histogram, we now can isolate true reticulocytes that are here dotted in purple, and you can see them here, from these unghosted cells that are causing an interference. And because we can isolate them, we can remove them from the counting of reticulocytes. And therefore, in this technology, we are not having pseudo-reticulocytosis. We are reporting an accurate retic count, even in the presence of these common interference substances. And that is basically telling the laboratory that you have to go to the microscope fewer times, you have less workload, and most importantly, you have an accurate result, and you will not report out to a clinician a highly elevated retic count when the patient does not have that. And this is really critical. So you have a reliable count in the presence of abnormalities. So again, basically the key message I think is that laboratory hematology is more than counting cells, and the major limitation of modern day laboratory hematology is not lack of parameters, is not lack of new counts of cells, especially if you have new counts that are not providing an improved performance demonstrated by raw curves. The major limitation of modern laboratory hematology is the fact that we are no longer appreciating the morphology, and we need to change the game. And we have now an instrument that is looking at the cells for you at the same time that it is counting them. And we just need to use this technology to improve our patient care and not allow, without having an increase in workload and labor costs. Thank you so much, and I'll be happy to take any questions. Thank you.
Thank you, Dr. Chaves. If you have questions, please feel free to submit them at this time. Okay, there are no questions in our queue, so that will conclude our presentation. Thank you for attending and enjoy the rest of the conference.